Hello, thanks very much for all of y'all who came out today. Thank you to the organizers, thank you to the rest of the speakers who've done a wonderful job today, kind of really giving an excellent overview of a lot of really important areas, including integration, different modalities of using these kinds of psychedelics in treatment settings, and really focusing in on MDMA. And I'm going to be actually focusing in today on psilocybin, because that's been the area that I've been working on for the last few years with the group at Hopkins. And so just to recap a little bit, a lot of this stuff has been covered very nicely by some of the prior speakers, so I won't belabor it too much. But these classic psychedelics that we'll be focusing on today are specifically these serotonin 2A agonist or partial agonist compounds. And that's their main mechanism of action, but they work on a number of other neurotransmitter systems, we know that. And the reason that that's the case, among others, is if you look at their structure, in the middle there is serotonin, or 5-hydroxytryptamine, and it's got this very nice kind of what they call an indole structure, which is that 6-sided ring with a little 5-sided ring right next to it. And many of these classic psychedelics are built off that same kind of shape with that indole structure. And so you see psilocin, DMT, and LSD all have that. And mescaline is not quite the same, but similar. And so as a result, these drugs are kind of processed in a way that they are working in the serotonin system. And the drug that I'll be, again, focusing on today is psilocybin. And so psilocybin comes from mushrooms, and it grows in over 100 different kinds of mushrooms that we know about. They're all over the world. And these drugs have a kind of long and storied history that we know a lot about from kind of the Western standpoint. They were really discovered more or less in the 1940s with Dr. Albert Hofmann's work. And once they started to sort of get a little bit of notoriety, and people were using them, people like Aldous Huxley or Humphrey Osmond, who was a British psychiatrist working in Canada, they really started to take off, and people were trying to understand, what are these drugs, what do they do, how do they work? They seem to be a little bit of a mystery. They're quite different than a lot of the other drugs that we knew about. And so as a result, they had a whole slew of different kinds of names that were attached to them. Fantastica, they were called psychotomimetics, they're called entheogens, as you heard. The one that I like is this psychedelic term, which was coined by Humphrey Osmond in 1957. Really good paper. If you haven't read it, I think it's seminal in the field. And at that time, he was having a little running correspondence with Aldous Huxley, trying to figure out a name for these compounds, and psychedelic was what Humphrey Osmond came up with, and it was part of a little nursery rhyme game that they had going. But to fathom hell or soar angelic, take a pinch of psychedelic. So what they proposed was that these drugs were mind manifesting, or they were soul revealing, if you will. So that's kind of the root of this terminology. And what we know about these drugs, these classic psychedelics, is that they don't actually cause physical addiction. So that's another piece of the puzzle here that makes them unusual as compared to most of the other drugs we know about. They don't really cause craving. They don't cause a lot of physiological disturbance. So they're fairly non-toxic for the most part. But they do produce these very unusual thought, mood, and perceptual changes. And the closest thing that we know of that is related to these psychedelic drug actions is dreams, contemplative and religious exaltation, vivid involuntary memory, or sometimes acute psychoses. So as we've talked about, this is a very unusual kind of state of consciousness that can be brought about by these substances. And that's one of the reasons why they've been, I think, so compelling as these, on the one hand, tools for psychiatric and biomedical research, and on the other hand, why they may have been so demonized for so long. But in terms of the non-toxic nature of these compounds, this is a graph I like to show specifically to medical audiences, because if you kind of look at these top 20 abused substances, I had a group of scholars, doctors, and medical professionals in the UK kind of go through and rate, what is the relative harm to others and harm to self that these drugs are causing. And you can see alcohol, which is legal, and you can walk around the corner and go buy some if you want, is one of those drugs that causes quite a bit of harm. It's up there with heroin, crack cocaine, methamphetamine. And if you kind of go way down the list to the very bottom, you'll come along the drugs like MDMA, LSD, and psilocybin mushrooms there. So relatively low risk of harm to self or others, unless you're taking them in a dangerous situation, or you have some sort of contraindication like Jane was talking about before, in which case there can be some complications. But going back further than the 1940s, there's a really long history of use among indigenous peoples of these kinds of substances. So they've used not only psilocybin-containing mushrooms, which were called Teonanacatl by the Aztecs, or something like a divine flesh is what that translates to. But there's also a long history of use of ayahuasca, of mescaline or peyote, and so those kinds of plant-based psychedelics have been in use for religious or sacred purposes for thousands of years, and we have a good record of this. However, there was this period, after the 1950s, when there was a lot of pretty rigorous research going on at the time, and in the 1960s, when these drugs started to get out of the lab and people were taking them recreationally. It became something of a cultural phenomenon, as I understand it. I wasn't around for this, unfortunately, but there's this whole movement that was associated with the counterculture, with the anti-war movement. There was so much social and political upheaval at that time, not too different perhaps from today. And as a result, there was a big backlash, in particular the Nixon administration in early 1970s, and a lot of others who were kind of on a prohibitionist type kick, put these drugs into Schedule I. And so from about 1971 on, it was really difficult and stigmatized to do any work in this area. So luckily, fast forward about 20, 25 years, and you start to see this work begin to emerge. And for a long time, in the midst of that, there were people doing good and serious work. Dennis McKenna will be coming up after me to talk about, the work that was continuing on, during that time, before the 1990s and then after. But, it kind of gotten a little bit more mainstream momentum. And, Michael Pollan's work recently has been kind of a big harbinger of that, in terms of getting a lot of people to take this somewhat seriously and look at this again as, a real, having a real potential in medicine, psychiatry, psychology. And so, I got very fortunate to come on board and work with a team at Johns Hopkins in 2012, and they started this work when I was still in high school, as a matter of fact. So in 1999, which is when I was graduating from high school, Roland Griffiths was working with Bill Richards, Bob Jesse, and others at the Hefter Research Institute and these other groups that were trying to get this human psychedelic research off the ground here in the US. And specifically, they wanted to study psilocybin in humans, and so they went about and got those licenses and got this, got the ball rolling. And since then, we have done about 10 different laboratory studies administering psilocybin to humans, as well as other kinds of hallucinogenic compounds like dextromethorphan, salvia divinorum. We've administered psilocybin to over 300 people, more than 600 different sessions. We've got a team now of over a dozen researchers, psychologists, psychiatrists, pharmacologists, neuroscientists, and so forth. And we're just one group among a number, but I'll be talking a lot about the work that we've been doing just because I've been familiar with it more so as a result of being there. But I definitely want to acknowledge our colleagues at the University of Zurich in particular, who've done probably a lot of the best work, in the field. Franz Wallenbeiter, Katrin Preller, Rainer Cranman, and then there's a group at Imperial College London, David Nutt and Robin Carhart Harris, and other groups, NYU, Alabama, Birmingham, UCLA, Madison, University of New Mexico, spreading contingent of ayahuasca researchers in Spain and Brazil, And, a lot of this work is being kind of championed by the Hefter Research Institute, the Beckley Foundation, and MAPS. So those are some of the major players in the field at the moment. And so this is a photo of the group, some of the group that were there when I got there in 2012. And this is us now. And so there's, we've expanded quite a bit. And we hope to continue to see that expansion at Hopkins and throughout, the rest of the academic research area. But yeah, I'll be focusing a lot on the work that we've done at Hopkins since 2000. And just as a kind of synopsis here, we've started off, which is kind of the norm when you're doing these kinds of pharmacology research studies, administering the drug to healthy, normal volunteers. And the main thing that we're trying to do is figure out what happens when you give these drugs to people who are healthy and don't have any sort of history of physical or mental health issues. And that work developed over time, so that we did a few studies that way, and then started to take those findings and try to incorporate them into clinical types of interventions that we could use to help people who are suffering from addiction, anxiety, depression. And so that's kind of what I'm going to walk through today in terms of explaining more or less, what we've been doing and where we're hoping to go over the next 5 to 10 years. So when we do these drug sessions, they last about 8 hours. But, as we've talked about already today, it's not just the drug that's administered and people go on their way. We spend a lot of time preparing people beforehand and then kind of integrating those sessions afterwards. But throughout the actual drug sessions, there's 2 people present, typically a male and female dyad. And the participants themselves are asked to lay down on a couch. They usually have their eyes covered, listening to music with some headphones. And we, kind of prompt them to focus their attention inward and to trust, let go, and be open, which actually goes back to that Walter Pankey and Good Friday experiments that were going on at Harvard back in the early 60s. But as you can see, here's a couple of my mentors, Bill Richards and Mary Casamano, who are sitting there posing in our session room, one of our session rooms at Hopkins. And this is kind of what the sessions would look like, ideally. So some of those early studies that were initiated back in 2000 were really, again, what are those effects of psilocybin that were distinguishable from other types of drugs? And so to try to get an active control condition, we were administering, or Roland and the team there were administering methylphenidate, which is pretty much a dopaminergic drug. It's a stimulant type of medication, usually administered for ADHD. And we gave people methylphenidate or psilocybin, and they didn't know what they were getting. And then we asked them to sort of tell us about their experience, if you will, or give us ratings of what it was that they found salient about the experience. And, congruent with the findings from that Good Friday study back in the 1960s, and these were not seminary students, these were, again, healthy, normal volunteers. However, these people were talking about, these experiences of unity that they were having under the influence. They're feeling like everything was one. They were connected to everything around them. Feelings of sacredness, intuitive knowledge, transcending space and time, a deeply felt positive mood like universal love or peace, and a sort of paradoxicality or ineffability of this kind of experience. And that was kind of what shook out in terms of what is it that is a hallmark feature of the drug experience when you administer it under these kind of prepared conditions. And as you can see here, that was much more so the case with psilocybin than with methylphenidate. So there's a significantly greater, what we call mystical type experience under the influence of psilocybin. And what was really interesting is that this is not just an acute drug effect. So when you are administered psilocybin, you're kind of feeling the effects for somewhere in the neighborhood of 6 to 8 hours. But we kept up with these people, and we would see them for 2 months, or sometimes 12 months, or 14 months, or even beyond that, and kind of ask them what's been going on since your experience, and how much would you say that that's kind of stuck with you. And this is 2 months after the session. People are saying that these black bars are here explaining kind of their ratings of the way that their drug experience influenced their well-being. And so 2 months later, they're saying that the drug experience really kind of gave them a sense of enhanced well-being or life satisfaction that had carried on since the experience. So it's not something that is kind of confined in time to that one day when they have the drug, but it kind of can go on for some time. And just to make sure we were thorough about this, we were also asking people's spouses, their friends or close coworkers, people that they were very close with and who agreed to be part of the research. Have you noticed any changes in Bob since his study participation? And you're seeing there's a very kind of nice differentiation between 2 months after psilocybin versus 2 months after methylphenidate. So there's kind of this outside corroboration of these positive changes in the person's mood and behavior after the experience that, again, was persisting for at least a couple of months after the session. And what's really interesting is that this kind of attribution of meaning, spiritual significance, positive behavior change, it persists. It does not degrade over time. And so about 14 months after the experience, you can see it's still rated very highly in terms of the level of meaning and spiritual significance that people are attributing to it. So, that's something that you can think of as a kind of a pharmacologically unique type of effect. It's not something that you get when you take an antibiotic, for instance. So, it's something that it bears more study because these kinds of long-lasting effects obviously have some real potential in terms of clinical use for something like a chronic illness like addiction, for instance. So one of the things that we kind of went back to look at after these initial studies in healthy volunteers was what was the impact of these kinds of mystical types of experiences on their personality over the long term. And what we found was using this, what they call this ocean model of the personality. It's measuring 5 kind of distinct domains: openness, conscientiousness, extroversion, agreeableness, and neuroticism. The one that kind of stuck out, that changed after these mystical experiences with psilocybin, was that people were reporting increased levels of openness to experience, which is a quality that's associated with aesthetic appreciation, imagination and fantasy life, and tolerance of others' viewpoints. And so those kinds of things were actually seemingly increasing after these types of experiences in the laboratory, which is a really interesting point, which again kind of shows that these drugs and the experiences that they entail can have these lasting changes in terms of the way that the person sees themselves and also is behaving in the world. So we also had a number of what we call challenging experiences that came up in the lab. This is obviously not something that is a surprise, from a kind of more anecdotal side of things. People have been talking about quote unquote bad trips for years, since the recreational use in the 50s and 60s. And so we saw, in these studies, we typically see anywhere from 20 to 40% of the participants at the very high doses that we're using, 30 milligrams per 70 kilograms body weight, will have these types of experiences. And sometimes, these can come on early, sometimes they come on late. It's somewhat unpredictable. We're still struggling to really figure out who and when and why are having these experiences. But the good thing that we have kind of been able to isolate is that as long as people are well screened and as long as we have appropriate follow-up integration, we're not really causing any sort of long-term adverse effects in these people. So they may have a very challenging experience under the influence on the day, but these have not really kind of gone on to become psychiatric problems, which is one of the big concerns in doing this in a medical setting. So we've also kind of taken a look at the way that this can influence people's spiritual lives. One of the things that we're working on now is a kind of a recreation, if you will, of this Good Friday study, where we're administering psilocybin under prepared conditions to priests, rabbis, religious professionals, to sort of see how it influences their spiritual lives. That study is still in progress, but this is one that we finished last year, I believe, which was one of the larger studies of psilocybin, and it actually was addressing a number of questions. But we took 75 people. These were, again, healthy normals who had an interest in learning how to meditate. They had an interest in kind of spiritual practice, and we taught them how to meditate, and we also administered to them either a very low dose of psilocybin or a high dose of psilocybin. And this third group got the high dose, plus they had these support groups that met up after their experiences. And so, we wanted to see what was the effect of the drug and the dose of the drug, but also the dose of kind of interpersonal support that they were receiving. So some of these people, the ones in the dark blue here, were having weekly kind of support group type meetings. They were optional. You could come if you wanted, or you don't have to if you don't want to, obviously. But these people would basically come and talk about their experiences with other people who had been in study. And we would lead these groups to, kind of track the way that this was influencing their day-to-day life as well as their kind of spiritual practice and meditation practice. And what you can see is that, obviously the dose was a big factor here, because the people who got the low dose with the normal level of support, which is a more one-on-one support, were not having the same level of positive social effects, positive behavior change, or spirituality increase that you see the people who got the higher dose. However, you also see that the people who got the higher dose, plus the extra level of group support, are actually having even more altruistic positive social effects and more positive behavior changes. So this is an interesting question in terms of the way that the context in which these drugs are administered interacts with the kind of long-term effects. And so even traits like meaning in life or forgiveness, are affected not just by the drug and the dose, but also by the level of interpersonal or group support. And that's why I think it's really important and good that people are starting these groups like the Portland Psychedelic Society, where folks who have had some experiences that they'd like to share or talk about, are able to kind of find like-minded people that they can kind of be open with about that. Some of this work I was mentioning before from Zurich, Franz Wallenweiter's lab, has been looking at the more basic sort of mechanisms behind the psychedelic effects. What they're finding here is, for instance, that psychedelics can kind of imbue enhanced sense of meaning to things that would typically be considered meaningless. Those kind of neutral pieces of music were under the influence of LSD found to be more meaningful, and that was associated with activation in the posterior cingulate cortex. Similarly, the sort of sense of self and other or social cognition is being affected by the psychedelic, particularly by psilocybin, LSD, and that's also associated with this activation in posterior cingulate. And so, as we're learning more about these drugs, at a kind of basic level, what we're understanding is that they can change the way that we perceive meaning, change the way that we perceive ourselves and others in the world, and change kind of at a biological level our brain function, so that there's more of this interconnectivity that could kind of help us shift perhaps our brain function, but also our perceptions, and our mental health status. So that's really kind of been the seminal work that's launched us more into this clinical side, looking at people who've got a number of different issues that we thought perhaps these kinds of experiences would be useful for. And one of the bigger studies that we published in 2016, which was a follow-up of earlier work in patients with life-threatening illnesses. In this particular trial, we're doing work with cancer patients who had anxiety and depression. And what we're finding was that when we were administering psilocybin to these folks, they were having antidepressant effects, anti-anxiety effects, and that these effects were lasting as long as 6 months after a single high-dose administration. And so, that is, in and of itself, a really important finding, because, these people typically are not, doing very well with the kinds of treatments that are available. However, the lasting nature of these antidepressant or therapeutic effects is also kind of unprecedented in the sense that typically people have to be on these kinds of antidepressant medications daily for months or longer in order to get any benefits. And so if you can kind of change the paradigm where people only need to be administered these kinds of medications like psilocybin, once or twice or a few times, every so often, it really reduces the level of exposure to side effects and other kinds of untoward adverse events that you would get from a long-term medication regimen. This is more of the same. This is kind of the number of people who are having these positive benefits in depression and anxiety. Our findings were replicated by a group at NYU who did a very similar study with cancer patients and found the same kinds of antidepressant effects. And work has been expanding in London as well at Imperial College, looking at treatment-resistant depression, which is something that is kind of in the works on a larger scale right now, where there are going to be a number of laboratories kind of working together to see if this is actually an effect that holds up. But these are some of the early findings from London in terms of this treatment-resistant depression and the antidepressant effects of a single dose of psilocybin. Again, we're still trying to get under the hood and understand why this is happening the way that it does happen. Why is this having these long-term effects? We're finding things like change in amygdala cerebral blood flow is important in predicting the effects that last beyond the first few weeks. But again, that's to be continued. It's something that we're still trying to parse out as we do more of this kind of brain-based neuroscience research. So I'm going to switch gears a little bit. There's a lot of kind of comorbidity or co-occurrence between depression, anxiety, and addictions. And so one of the areas that we've been focusing on, and actually that was a big focus of early LSD research, was looking at treatment of addiction, and particularly alcoholism. This is some research that was a number of studies that were done back in the 1960s with LSD for treatment of alcoholism, showing that people who got the LSD as opposed to control treatments were doing about twice as well, or had about twice as good odds of getting better than the people who got those control conditions. And that's a very exciting finding because it's still such a difficult problem, that we don't have very good treatments for. And so Michael Bogenschutz and colleagues at University of New Mexico and now New York University have been working on some follow-up research using psilocybin as a treatment for alcoholism. That's typically incorporated within a structured intervention with motivational enhancement treatment. And what you can see here is some of their pilot results showing that the people who undergo this kind of treatment, at least in an open label pilot study, are reporting significantly decreased percent drinking days and percent heavy drinking days, which is one of the ways that we measure the efficacy of these kinds of treatments. Our group at Hopkins has also looked at cigarette smoking as an addiction that we don't have very good treatments for, and that we'd like to figure out if we could kind of harness the power of psychedelics for behavior change in this direction. And this was kind of from our first published paper in 2014, where we found that 80% of our participants were able to quit smoking after 2 to 3 doses of psilocybin in a cognitive behavioral therapy context. And those results are very good because usually you see about 30% of people quit with the best available treatments right now. And those findings were pretty enduring because we kept talking to these people for 3, 4, or more years after, and found that even about 2.5 years on average later, over half of them were still abstinent, or 60%. So one of the big questions that we kind of continually come up against is, how does this work? Why is this happening this way? And beyond the kind of biological mechanisms that we're kind of examining using neuroscience techniques and others, there's been a lot made about this kind of mystical type experience and the meaning that's associated with that. And what we found with our smokers, for instance, was that the more meaningful the experience, the greater their change in their confidence to abstain from smoking, the more of the mystical type effects that they had, the greater reduction in smoking craving they were having. So this seems to be kind of like a key linchpin in terms of mediating the outcomes. And then it's an interesting one because even with drugs that are a little bit distinct in terms of their mechanism, like ketamine, which works in the glutamatergic system, you're still seeing a similar type of pattern here where the more mystical types of experiences can be associated with a greater increase in motivation to change. And what you can see here is people in the kind of top right-hand corner, there's these 4 folks. I think this was a study done in about 10 New York cocaine-using individuals who didn't want to get any better. They didn't want to stop using cocaine. But the 4 of them who had a very kind of mystical experience under the influence of ketamine just spontaneously quit afterwards. And that was something that, again, is very consistent with our research with smokers and with people with alcohol use disorders. So, there's a lot of kind of mechanistically speaking reason to believe there's some crosstalk between the serotonin system and the glutamate system. which could account for some of the similarity between the ketamine effects and the effects of psilocybin. We've done some work just looking at what we call kind of comparative pharmacology of these glutamatergic compounds versus the serotonergic drugs like psilocybin. And specifically, this study was a really neat one where we took 20 kind of experienced hallucinogen users and under double-blind conditions gave them either a placebo, 3 doses of psilocybin, or a fairly high dose of dextromethorphan, which is similar to ketamine, glutamatergic dissociative anesthetic. And what you can kind of see here is this psychograph which shows the effects, and kind of very nice orderly effects with psilocybin having kind of more and more spiritual effects as you got to the higher doses, but seeing a lot more disembodiment when you look at the effects of the dextromethorphan. And so, in terms of understanding what's the kind of brain chemistry and subjective effects of these drugs, it's still something we need to do more work on, but it's a very fascinating area. There's been a lot of interesting preclinical research. This is typically research work that's done in animals and cells, but a study finding neurogenesis, or the birth of new cells in the hippocampus after administration of psilocybin in mice. This is the kind of thing that kind of led to this further work that was published just this year, finding that but cells that were administered LSD and similar compounds were showing synaptogenesis, so growth of new synapses, neurons, and dendrites, and that has kind of caused this new terminology, psychoplastogens, talking about how these drugs can kind of alter neuroplasticity, and we think that could obviously have a lot of really positive ramifications for the therapeutic benefits. But from a more psychological standpoint, what does that look like when you're kind of in the first person or the experience? And something that kind of grabbed me when I started doing this work was, this is kind of verbatim comments from 15 of our smokers from the initial pilot study, kind of just asking them in retrospect, and I think this was 6 months or 12 months after their experiences, what was most memorable. And if you just look at, participant 405 said, well, it changes what I believe, we are all one and divine. Look at the next person down, 406. The most memorable thing to them was the awareness that all is one, and the realization I'm an integral piece of the one's puzzle. Yeah, skip down to the next person, 410. They said, the most memorable thing was the oneness with the universe, being forgiven. So this is a number of people who never spoke to each other about their experiences. They didn't know each other, they didn't know anything about this. Many of these people had never taken psychedelics, period. And they came in because they're just trying to quit smoking. But this is the kind of thing that they were telling us. And it really does kind of strike you as being more than just, I would say, coincidence. And so we do think this is, again, kind of one of the hallmark effects of these drugs. And one of the things that I've kind of put out there recently is that, I'd like to think of this as kind of like an inverse PTSD-like effect of these drugs, in the sense that when you have a trauma, you can have a single incident that leads to like these lasting, usually negative symptoms and mental health issues. Whereas we kind of have an inverse model here with these psychedelic mystical type experiences. When people have them, it can be a single very positive experience that kind of leads to these ongoing positive mental health ramifications and benefits, which is unusual in the kind of current medical paradigm. Usually you have a course of treatment slower. It's not something that happens all at once. And so it's a way of thinking about these experiences that we hope will make sense to clinicians and people in the medical field. Last 4 years I've been kind of working on this randomized clinical trials, the randomized controlled trial of psilocybin for quitting smoking. Since we had really good results with the initial pilot study in 15 people, we decided to take a big group of 80 people, split them in half. Half of them are going to get psilocybin with cognitive behavioral therapy. The other half are going to get a nicotine patch with cognitive behavioral therapy. So this is not a double-blind placebo-controlled trial, but this is what we would call a comparative efficacy trial, where we take a drug that we know that works somewhat, which is a nicotine patch, and then we take psilocybin, and we're going to look at the results side by side. And so far, we're already seeing, that between the psilocybin and the nicotine patch groups, there are these changes that are, kind of shaking out differently. And so what you can see, for instance, here is this orange line is before they quit, what's their craving level, and where does that go to after they quit. And the orange line is the nicotine patch group. You can see the therapy, the cognitive behavioral therapy seems to be working. There's kind of some decrease in craving just naturally and with the nicotine replacement. However, the psilocybin seems to kind of turbocharge that, if you will. And so you're getting kind of this bigger decrease in craving after the psilocybin, which could be a biological effect. We're seeing changes in cognitive processes that are associated with processing interfering types of stimuli in the brain scanner. So we're doing brain scans before and after the quit day in these people, and we're finding that there's particular areas that are responsible for this, like the superior parietal cortex. So again, we're really trying to get under the hood as well, in the sense of understanding what's going on in the brain, as well as what's going on in people's first-person experience. So future directions, there's, I think, a lot of different ways that this kind of work can go in the future. I'm very personally invested in kind of seeing this developed in a clinical direction so that we can see helping people with different kinds of illnesses or other kinds of health conditions. But cluster headaches is one that is going to be moving forward in the near future. Also, there's a good possibility that this could help in neurodegenerative diseases, something like Alzheimer's, for instance. Combining psychedelic administration with augmented reality or virtual reality is something that we're looking forward to getting into. Combination with brain stimulation techniques like transcranial direct current stimulation or magnetic stimulation. And group psychedelic therapy or couple psychedelic therapy, we've heard a little bit about that. And we've also been doing a number of online surveys just to understand when people take these drugs outside of the laboratory, what kind of effects are they observing? There's a lot of methodological considerations that I won't go into too deeply, but it's just something to think about. A lot of the current medical model is really based on this double-blind placebo-controlled design study, which is difficult to carry out with psychedelics. If you get a high dose of psychedelics, you're typically going to know pretty fast within an hour or so. And so people who get the placebo, you usually know. And so what's the role of expectancy in these kinds of drugs and their effects? So it's something that we want to learn more about. And I think it's also very germane to the microdosing question, because that's something that would be more amenable to this kind of double-blind placebo control. But there's been even more work on just the placebo response itself, where people are being given these medications as open-label placebos and told, this is a placebo. It may or may not help your pain. And they come back and tell the doctor, this actually helped, thanks, doc. And so we were trying to understand what's going on there. And I think that it does have a lot of relevance to psychedelics as well. What's the best way to train both researchers and clinicians to administer these drugs? Because they can entail, again, some really powerful and profound experiences. There's people on many different sides of the fence on this, but Humphrey Osmond, again, in this seminal paper from '57, said, let me emphasize that those who have not themselves taken the particular substance with which they wish to work, preferably several times, would be wise not to use these agents in therapy. So that was what he said in 1957. I know that MAPS is working on training clinicians now for their MDMA studies, and some of that does involve use of or administration of MDMA to the therapists themselves. But there's also, of course, the late great Sasha Shulgin there, who tried many of these compounds that he created himself, and so that's something that will have to be worked out in the future. Something I've been very interested in is what's the therapeutic model for interventions with psychedelics. I'm kind of steeped in humanistic existential psychology is my background, and so I take a very much a Rogerian stance of unconditional positive regard being a very important role of doing treatment with psychedelics, both in the preparation but in the explicit sessions themselves. And I will have a paper out soon on that with Bill Richards, who's one of my clinical mentors. And how are we going to develop these as medications? Because it's not take 2 of these and call me in the morning. It's something that needs to be administered in a controlled setting with people who've been well screened. And so in those terms, it's a little bit more like getting an anesthesia where you have a trained anesthesiologist giving you this medication in the hospital, monitoring you throughout its effects, and then once it wears off is when you're kind of allowed to go. And that's the kind of model that we're thinking about seeing this kind of developed in the future, where people are going to be able to go to special clinics to get this kind of treatment for depression, anxiety, addictions, etc. Another really important and interesting piece that, I think is going to be really delicate, but at the same time exciting kind of new frontier is, the intersection of this Western biomedical model, which is kind of where Hopkins and a lot of these more neuroscientific and other kind of clinical groups are coming from, and the more kind of indigenous or shamanic models, which are the people who have been using these substances, who kind of discovered these substances, if you will, long before Western medicine. And so what can we learn from each other? And I think it's important not to kind of dismiss, one side or the other, because I think both have a lot to offer. So it's going to be important that there's some sort of way that we can kind of get together and bring, the best of both of those traditions, so that people can really get the most out of these kinds of experiences. So finally, I just want to say thanks again to you all for your attention, for being here. Thanks to Portland Psychedelic Society for bringing me out here from Baltimore. And thanks to the Hefter Research Institute, who has been funding a lot of this work at Hopkins, the Beckley Foundation, National Institute on Drug Abuse, who's also been giving us a lot of resources to do some of this research, and all of the people that you can see here who, Roland Griffiths, Matt Johnson, Mary Cosimano, Bill Richards, and all of the others that work in our laboratory and make this possible, as well as our study volunteers. But I'm gonna be happy to share any of these resources, papers, or answer any questions. So feel free to email me. My email is there. And yeah, that's it for me. So, thank you.
Test. Okay, I have a question here.
Some of the earlier speakers talked about the importance of educating legislators about the medical applications, usefulness of it. What is, as a leader in the field, what is Johns Hopkins doing to get this information to policymakers?
So we're not quite there yet, because really we need to get to the place where we've got these more conclusive data that we can kind of bring to people like policymakers and say, okay, we have rock hard evidence that this stuff works. And right now we're just kind of a little bit shy of that. We have all these small studies of 15 smokers where everybody had psilocybin. There was no placebo control. Even the controlled studies that we have are 50 people maybe. And so typically to get the kind of real evidence base that you need to prove conclusively that these are efficacious treatments, you're needing kind of in the ballpark of a couple hundred, maybe more people to show that it's safe, to show that it works. And so we're actively planning with other people, these big collaborative projects to do that, to gather that information, at which point we will be kind of approaching more policy-making type folks. But as it stands even, we're working kind of more behind the scenes with people like the Food and Drug Administration to understand what is it that we need to show you guys so that you can approve this as a medication. And, believe it or not, the FDA has been pretty awesome and very much on board in terms of trying to figure out what it is that we can do to show whether or not these work. And if it works, then they want it to get out there as well. So.
Next question's down front.
Okay, I kind of have two things. One is, were you using standardized extracts? And I'm just curious to know, like, the difference between using psilocybin in a tincture versus raw mushrooms, if you know anything about the different uses. And then why aren't they considering using this for, like, brain or spinal injuries if it's causing dendritic development?
Both good questions. So what we've been using so far is just pure psilocybin. It was made by our colleague, Dr. Dave Nichols, who's so it's just a synthetic psilocybin that's been used so far in our studies. But we did get a DA approval and grew some psilocybin mushrooms in our lab. And so we ground those up, and we're hoping to start giving them to people at some point in the future, under double-blind conditions, kind of experienced psychonauts, and giving them both the pure psilocybin and the psilocybin mushrooms to see if they can tell the difference and if there's any difference in terms of the outcomes. But yeah, that's something that we haven't gotten to. So in terms of the neurodegenerative or the other kinds of spinal injuries, for instance, we haven't gotten that far yet. We're working on a study that will be starting next year with Alzheimer's patients, so that's kind of the closest we've come to working in that direction. But yeah, we kind of have a kind of a lack of resources we need to expand in all the directions we'd like to at the moment. So that's kind of why we haven't gotten there yet. We've gotten to kind of the places we know there's a good signal, like depression or addictions.
Next question is in the middle.
Hi, yes. MAPS has published in great detail the protocols that they're using for their studies with PTSD and MDMA.
Mm-hmm.
And I'm really impressed with Johns Hopkins' work, and particularly with smoking cessation, and wish that there were some protocols for those studies. And I'm wondering if Johns Hopkins can make those available, at least in part, to people.
Well, we published our safety guidelines in 2008, which is more kind of, that's a Johnson, Richards, and Griffiths 2008, but that's really kind of how to administer psilocybin in kind of in a research or clinical setting safely in terms of screening and all that. I have a follow-up paper is coming out this sometime in the near future with Bill Richards in terms of kind of how to do the nuts and bolts of psychedelic psychotherapy. And in terms of the actual protocols, we typically use protocols that are already out there. So the CBT we use for psilocybin smoking cessation paper is kind of based on this CBT program from the UK, which is published. It's called Quit for Life. So that stuff is all out there, but it's probably not as easy to find as the MAPS has made it. So feel free to email me. I'm happy to send you what we do have available. And some of it is kind of like work that we don't kind of put out there into the general public until we finish, and so that's why some of that's not available now.
Hi, I'm curious about the research that's been done in terms of decreasing depression and anxiety in cancer patients. How have that decrease, how has that impacted their medical status?
So some of these people still go on to pass away from their cancer. Some of those people, get better. A lot of these people were in some level of remission, but at the same time, that wasn't something that, they have any real sense of where that's going to go in the long term. So we know that it's improving their mental health status in terms of whether it's having any sort of beneficial kind of impact on their physiological health and well-being, in particular the sort of like cancer or anti-tumor types of effects. We don't really have enough information to say that. It hasn't really been studied, not in a good controlled way yet, but I think it's an interesting question for future research.
Next question is to your right.
Hi, I'm just wondering, so you said you did administer some like ground mushrooms versus the synthesized, no ground mushrooms yet, just all
We
synthetic?
grew them, and we're planning to do it at some point, but again, it's kind of a throughput thing. We need to kind of focus our resources where we need to do it. So this is more of an intellectual curiosity question, as opposed to, getting it out there for medical availability, which is what we're really focused on. So we haven't done the kind of mushrooms versus psilocybin study yet.
So when you guys do that study, are you going to plan on looking at like full CMP, like full labs to see if there are liver effects, renal effects? Is that all going to be part of this study, or more the kind of, like as a clinician in developing my own studies, I'm wondering what I should be screening for, which patients shouldn't be able to ingest those substances, like hepatitis patients or, people with renal issues. Like, are you going to be just giving this to healthy volunteers, or also kind of looking at?
We would do healthy volunteers, but we've also, since we were working with those cancer patients, we kind of, and we're moving towards the Alzheimer's patients, we're working on developing, the safety guidelines to figure out which medication interactions are not good, what kinds of liver, but typically if you don't have fairly good liver or kidney function, or cardiovascular function, those are the types of things that we would screen as a potential red flag and not administer a high dose anyways.
Next question is over here.
You mentioned that you had pretty significant screening of participants, and I was wondering what your exclusion criteria were, if there were psychological trauma or things like that, and if so, for whatever those things were, how do you surmise that affects the applicability of your findings to a broader population who might want to use this treatment?
Yeah, so we usually do a pretty long structured clinical interview like the SCID or the MINI, which kind of really goes in depth. It takes 2-3 hours where I would sit down with the person and kind of go through a long list of symptoms and see if they've ever had it in their lifetime, if they have anything like that now. And those are the ways that we kind of suss out whether or not people meet inclusion or exclusion criteria. The real general exclusion criteria that we use are, for mental health purposes, history of psychotic disorder, like schizophrenia, as well as bipolar 1, and yeah, those are pretty much the main ones. You know, there's other ones that could be contraindicated, like personality disorders, severe post-traumatic stress, if they're coming in for like a smoking cessation study where that's not what we're focusing on. You know, but yeah, does it affect the applicability? I think so, but that's a big problem in a lot of research. You know, they just want cigarette smokers who don't drink, for instance, you know, and yeah, or they want people who have alcohol use disorders, but they don't use any other drugs. And in the real world, it's not like that. And so that's kind of a wider problem in this clinical research, but we are hoping to do some more dual diagnosis research in the future where we can get people who are depressed and have alcohol use disorder, for instance, and see if we're able to get them, you know, into a better, you know, space, both physically and mentally.
We only have time for a couple more, so please be concise.
If a person has used the psilocybin recreationally prior, does it affect a more controlled use of it in a clinical setting?
We don't know that very well, but many of our studies, we screen out people who have excessive use. So if you use, you know, a certain number of times, we'll say, okay, you know, our hypothesis is that this may not be as salient or as meaningful to you if you've done, you know, 200 psilocybin sessions in the past. Whereas if you come in and you say, you know, we do have grandmas who come in and say, I've never smoked a joint, I've never done any drugs, I've had a glass of wine before, that's it. And, you know, so we kind of common sense have thought, you know, those people are probably going to have these more pronounced effects than the psychonauts who've had a lot of experience. So for these clinical applications, we tend to fall more on the side of people who are naive or who have limited histories of use. But in terms of how that really, whether or not that really affects the outcomes, we can't say for sure yet. So.
Down here in the middle.
Yes, is there any treatment of migraine headaches?
Yeah, so people self-treat with or self-medicate with psilocybin, with LSD, and so it's something that makes sense in terms of what we know about these drugs, you know, from a physiological standpoint, but there hasn't been any like controlled clinical trials, unfortunately.
I wish I could remember the name, but I know that there is a corporation that has obtained a patent on its synthetic psilocybin. And
Yes.
there was some discussion that they're interfering with research efforts. Well, the question is, do you have any, are they actually interfering with research? But it also makes sense that they could even patent a plant.
You can't patent the psilocybin, but you can patent the way that you make the psilocybin, so that's kind of a loophole. But actually this group, which is called Compass Pathways, I think who you're referring to, I believe what they did was kind of patent the way that they are administering the psilocybin treatment all around. And I don't know too much about this. Everything I've read is more secondhand. But they're using a for-profit model, which includes a patent, to try to drive phase 3 clinical research, which would get FDA approval, hopefully, for psilocybin for depression. So while there are some people who are concerned about the kind of proprietary and, you know, profit status of all of that, I think from a more utilitarian standpoint, it's going to help people get access to treatment potentially more quickly, and they are driving more research that's going to happen soon. They just got literally, I think my dad texted me yesterday about this, that FDA kind of gave them the green light to do this breakthrough designation of psilocybin for treatment-resistant depression. So, I mean, unfortunately, money talks. But if they're moving this forward, I think it's kind of a good thing. And those kinds of patents do run out, so.
This might be the last question, so please be brief.
Hi, I'm curious if there are any indications that maybe disorders that are considered exclusion criteria now in the current studies, you know, this critical period of legitimizing these medicines, if in the future, maybe 10, 20 years out even, if things like personality disorders, bipolar disorder, might be disorders that are under study.
Yeah, I think they will go that direction, and I mean we've already been there. Stan Groff and you know, a lot of the clinicians who were doing the initial work in this field in the 50s and 60s, the Spring Grove group, they were doing research with personality disorder, with patients that we would call today personality disorder patients. They were doing work with patients who had psychotic disorders. Some of them got much better too, and we still don't understand what was going on there, but because this work is in such a kind of delicate area right now, we really wanted to start in places where we had the least kind of risk, and so that's why we didn't go there, or that's why like a lot of work is not moving in that direction quite this minute. But I think once we establish safety on a bigger scale, you'll see some of those kinds of indications kind of get underway in research.
Final question?
So you had mentioned how mystical experience is a key for the healing conditions of this, and I was wondering how either the researchers help create that framework or how the participants get to experience that, because there's a lot of different ways that people could do it on their own, whether in nature or lying on a couch, and how mystical experience can be encouraged.
Yeah, that's an interesting question. From our standpoint, we don't really try to prime the mystical experience too much. We think it's a little bit heavy-handed, but we do kind of go over here's what could happen, particularly with our naive patients who have never had any experience, mostly because we don't want to just throw them into an experience with any kind of idea of what could happen. But yeah, I mean, we do kind of tell them this is something that people tell us and that they sometimes have seen happen. Obviously, people read our papers and popular media as well, and they can surmise their own kind of conclusions from that. But really, all we do, or what we kind of strive to do, is provide a safe and supportive context where they can have whatever kind of experience arises for them, and then try to help them make something meaningful out of that experience in the days and weeks following. So,
Thank you so much. Another round of applause for Al Garcia Romeu.
thank you.